You are a lively group of people. Help me today, Riley, okay? With attendance. I know we have a couple. I've heard from a couple. Maybe some more will come in. So Amber, I have activated a module and it's out of order from the, but it's in order with the book. So that's good, right?
I don't know which one.
So we need to finish up some pharmacology. This won't take long at all. I expect this to be about a 20-minute lecture maybe. If not, then we'll make do with it. And then we're going to move into cardiology. And we'll probably spend the rest of the week on cardiology. Next week, there's the reason for the change. Next week, you will do your BLS, your CPR. So it'll take a couple of days to do that. You will have another instructor doing that for you, not me. I have to go be an actor in a skit, and I have to go have a heart attack. So I'll be over in the CWL auditorium suffering from chest pain. And yeah, did you do that once before? Did you see me have a heart attack before? What? What? Why?
I don't know, it was.
Well, tell me. I need to improve.
It wasn't even that, it was like the nurses, they were just kind of weird about it.
I understand.
So stage that it was like not serious.
I think that's the same.
It was serious when I was having my heart attack though, wasn't it?
Yeah.
Or the medical thing where
Yeah.
that thing.
Did you go to that too?
Yeah.
Did you see me have a heart attack?
I don't remember who had a heart attack.
It was me in that chair down there with the dental people working on me. And
And you said,
you remember now?
Yeah.
Okay. Anyway, that's what I have to go do. And,
might swing by.
huh?
You might swing by.
Okay.
Go Green.
Yeah, yeah. Well, my name's John when it comes to that day. And so it's hashtag Save John. Crazy. Anyway, you have any questions from lab from the other day? Anything I need to clean up? Any controversy over what you might have heard? What you heard in one room versus another room versus in here? Sometimes that happens. Different points of view on things. No?
Nope.
No, Luke?
Negative.
Negative. So let's clean up these drugs, and if you were to make a drug card about these are some of the highlights that you need to know about them. So we're going to go with the oral medications. Remember, that has to go into the GI tract. So a nitroglycerin, even though it's in the GI tract, technically it's a sublingual administered medication. So look at the oral glucose. We talked about this quite a bit the other day. Oral glucose, I have one in my mouth right now. I have this peppermint tucked over here like a dip of snuff. And it's oral glucose. It's not being absorbed through my mucosa in the mouth. I'm swallowing it and it's slowly getting into my bloodstream as it's absorbed through the GI tract. When we have a hypoglycemic patient, we give them this, and we already know this. What's the big rule here? They have to be able to protect their airway, right? They have to be able to swallow, follow orders, protect their own airway. If not, we don't give it. So if they're unconscious, we don't give it. Do they need it? Yeah, but we don't give it. So what's our alternative? Do we do IVs? So you need ALS? Is that the only alternative? Because I think as an EMT, you may not know and have the ability to do everything, but you at least need to know where you can go and get it. You have to know of the resources. It's a lot of resource allocation. So you said IV, you said by the mouth. Is that it? Have I exhausted treatments? There's a nasal what? So don't, okay. It's a nasal hormone. The hormone is glucagon. I'll spell that for you. Once again, remember, you cannot give that as an EMT unless it's medically directed. Glucagon. Glucagon is a hormone that's secreted by the body when the blood sugar gets low. Your own body, your body right now has glucagon in it. And if your blood sugar got too low, you would release that into the bloodstream, and that would cause the liver to kick out something called glycogen. 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 My writing's off today. Glycogen. And glycogen is just a form of glucose, technically. So your body stores extra glucose when you have a surplus to come in times of need. So you're right, Jordan, that can be given intranasally. So there is intranasal glucagon. You may encounter a patient who has it. It's just not something we have. In EMS, if we have it, it's by IM injection. And that's given by paramedics. So if a paramedic's having a hard time establishing an IV, therefore can't give sugar through the IV, he or she could administer glucagon IM. Now glucagon is expensive. I'll just be honest with you that there's a limitation to why we don't have it everywhere. It's just expensive. And it may not work. We'll get into more of this when we do endocrinology. This hormone, aka drug, may not work. Because if they've already exhausted their storehouse in the liver, like you take a chronic alcoholic who would rather drink than eat something substantial, they're malnourished, they can run out of glycogen really quick. Somebody, you've probably heard of people who do like endurance events, athletic events. They'll go and they say they get their second wind. They're like they're just about to collapse, and then they pick up and go some more. They just got a release of glycogen from their liver. So you get someone at the back side of that release, that drug may not work. That makes sense to you? So I just need you to know about the alternatives to oral glucose. And they're usually ALS involved. Cool? Is the fancy little tube that's in your bag, is that the only oral glucose you can give? No, like I said, I've got some in my mouth now. Give them a sugary drink. A fruit juice is 100% sugar. I mean, if you're trying to lose weight, you certainly don't want to be drinking juices. That's way too much if you're trying to lose weight. So if I give one of those to someone suffering from low blood sugar, it will bring it up very, very quickly. Peanut butter is full of sugar. It's also got some protein in it, so it'll probably last a little bit longer. This is a quick fix, but it's not the fix. It's just to wake them up enough and then they need to substantially eat after that, okay? So once you give this and you get the desired results, the game's not over. We have to keep working on it. When we study diabetes in detail, I'll talk more about it. Aspirin, it is a pain reliever, but we are not giving it for pain. We're giving it for its antiplatelet properties. We're giving it for its antiplatelet properties. So you got these platelets in your blood, and their primary purpose is to form a clot if you get injured. So if I cut myself, there's a cascade of hormones and chemicals that are released that cause the platelets to what we call aggregate. You know, if you pour cement, if you pour concrete, there's an aggregate in there, and that's one of the things that binds all the structures together to make concrete. Same type of deals going on in your bloodstream. We have particles in there that want to stick to each other under injury. Normally, they're not very sticky. They just slip by each other without any adhesion. But you get injured, it's going to stick. And then the next one will stick, and the next one will stick. And pretty soon you've got a blood clot. We'll talk later this week about the arteries in your heart getting injured. Therefore, it makes the platelets stick together, and then we end up with clots in the coronary arteries of our heart. Aspirin prohibits that. Careful. Aspirin will not remove a clot once it has formed. It takes a different kind of drug to do that, and one we don't have at the BLS level, okay? There are drugs that can be given in the hospital and by some paramedics that will go in and dissolve the clot. Those clot-busting drugs like TPA and streptokinase and things like that. But it will help keep clots from forming. This is why there used to be this recommendation that if you were 40 years old, it used to be recommended to start taking a baby aspirin a day to reduce your risk of heart disease. I didn't do that. And my doctor said, well, you're supposed to. And I said, well, I'm not going to. Why didn't I want to?
If you get on it, you're going to end up getting off of it, and then you're going to start forming blood clots, and you're going to be at more risk for heart attack.
Yeah, it's like I'm hampering myself. I'm removing my ability to clot if I get injured. I think one of the things that people don't understand about blood clotting is that it's on a scale. It's on a scale. And normal, let's just call that normal. Too much aspirin will drive you below normal, or you could the clot really, really easy. These people down here never clot. Well, aspirin's going to push you this way. ASA for aspirin. It's going to push you toward that way. And if you're on that end of it and you get a cut, what happens to the cut? Just bleeds and bleeds and bleeds. You can put pressure on it. It bleeds and bleeds and bleeds. Is that significant to you as an EMT if you find in the sample history a patient takes a daily aspirin? Excuse me while I get rid of this. I know better than to do that. But I like peppermint. You have a hard time controlling their bleeding. There are other drugs that look like aspirin that are very, very, very common. It's probably on your top 10 list. If not, I'm sure it's on the top 20. Coumadin or warfarin or Plavix. You're going to encounter those drugs. They're just high-powered aspirins. Coumadin, warfarin, is rat poison. It's the active ingredient in decon. When a mouse eats that bait, they're overdosing on Coumadin. And it pushes the blood clotting so far to the end of the spectrum that they bleed to death internally. Yet we have patients who take that. Patients who take those kind of drugs often have to visit the clinic very often to get a PTT test ran. You'll hear that term thrown around. And that's a timing of how long it takes the blood to clot, and that's how they adjust the dose in patients. They'll get a drop of blood and see how long it takes to form a clot. If it takes too long, it means they're on this end of the spectrum. They're at risk for strokes. Not strokes caused by clots, but strokes caused by brain bleeds. If you hear anything today, hear this. A patient who is taking an aspirin a day or an aspirin-like product, an antiplatelet, and I mentioned a few, Coumadin, warfarin, Plavix. Oh, there's a new one on the market. Jordan, you may have heard it in the hospital a lot. I think it starts with a B. And on the TV it says, this is safer than warfarin. Well, There's a lot of room to be safer, so it doesn't make it safe. When you find those drugs in the sample history, a simple bump of the head warrants transportation to the hospital. And I'm talking about a hospital who can handle brain bleeds. And usually if they can handle a stroke, they can handle a brain bleed. If they're a trauma center, they can handle a brain bleed. You take a little lady who is reaching under her bathroom cabinet to get some cleaning supplies and comes out and bumps her head, and she's taking some of this warfarin, Coumadin, aspirin a day regimen. That's a significant MOI. Why? Because she takes that. If they fall at all, trip over a coffee table and hit their head. Luke, that wouldn't bother you. It hurt, but it's probably not going to kill you. But in these patients who take these aspirin a day or aspirin-like products, it's very significant, okay? So don't just write it off because it looks simple. They bleed very, very easily. Sometimes this aspirin, did we call it an acid the other day? A salicylic acid? It's got a really low pH, and it's hard on the stomach. It will burn holes in the stomach. And if you burn through enough layers of the stomach lining, you start bleeding there. And then these patients will just be vomiting large amounts of bright red blood. By the way, Motrin, ibuprofen, those of you who eat it like candy because your shoulder hurts or something, that will burn a hole in your stomach too. Now, it's not an anti-platelet, but it is very hard on the stomach. So be careful with ibuprofens. And don't take more than needed or any longer than needed. And when those things bleed, trust me, it's a ferocious bleed. It looks like somebody's been decapitated in the bed. It's a lot of blood. When do we not give this? If they're allergic to it. Aspirin comes from the bark of a willow tree. So does it have a protein in it? Your body, patients who are allergic to this, they're hypersensitive to that protein. So we would note that in the sample history, right? Allergies to medication, aspirin. But they're having a heart attack. I think they need aspirin. Do they get it? No, they're allergic to it. Meaning that it's going to break out in hives, cause difficulty breathing, cardiovascular collapse. Do not give it if they are allergic. And that's what that word means, hypersensitivity. Contraindications, they have liver damage, bleeding disorder, or asthma, and should not be given to children. Some of you may be parents or will be parents soon. It's funny, they make children's aspirin. Do not give aspirin to a child. It could lead to a deadly condition called Rye syndrome. And that's a long process of death. It's horrible. And it's just seems to be caused by the administration of aspirin to a pediatric patient with a fever. So this old wives' tale, take 2 aspirin, go to bed, does not apply to a pediatric. Okay? Yes?
So does that mean you can't give aspirin to like an asthma patient, or does that mean
Yeah, it's contraindicated in asthma because it sets off those same leukotrienes and that chemical dump that causes the anaphylaxis or the difficulty breathing. It's just going to exacerbate it in an asthma patient. So it could bring on an asthma attack that would be really hard to stop. So it sounds safe, doesn't it? Bears children aspirin. Take 1 a day, you know. It's not safe. So as needed only. Sublingual meds. This goes under the tongue. The saliva, the pH of your mouth dissolves the tablet or the gel or the paste or the drops. And molecularly, they can cross through the membrane that's at the base of the tongue. So sublingual means under tongue. Under tongue. Piece of medical trivia for you. Any of you ever had a salivary gland stone?
Oh, yeah. Like back here.
Mm-hmm. That's a sublingual gland. You have salivary glands all through your mouth. You make about 3 to 6 cups of saliva a day, and just being secreted constantly out of your mouth. Well, if you get a stone in that, the duct is blocked and the gland will swell really big. Did you use lemon heads to try to relieve it? Lemon drops or anything? They're wild. If you ever have one, you'll know it. The problem with sublingual medications, I think the problem is sometimes when you give it to patients, you have to instruct them, hey, this just dissolves under the tongue. Because most of the time you put something in a patient's mouth, they're going to try to chew it up or swallow it. Now, the drug that we're going to use sublingual, and there are a lot of them, but the one we're going to use is nitroglycerin. That is abbreviated NTG. Nitroglycerin, NTG. Yes, it is the same ingredient of dynamite. It's the same ingredient in dynamite. Therefore, it's a very unstable compound. Nitroglycerin breaks down or degrades rapidly. That's why it's stored in glass. You can't store it in plastic. It will react to the plastic. So it has to be stored in glass. The glass has to be amber colored or dark so the sunlight can't hit it. If it was clear, light would just degrade it. Extreme temperatures will degrade it. Now, I want you to think about Farmer Joe, who's got a history of cardiac disease, and his doctor has prescribed him nitroglycerin. It's going to be on the dash of the feed truck at 110 degrees, right? And you're going to get on the side of the feed truck, and he's going to be clutching his chest, saying, I think I'm dying. Have you taken any of your nitro, Mr. Smith? No, but it's on the dash of my truck. Do you expect it to work? You want it to work, but it may not work because of the way he's kept it. It's probably expired, it's been in the heat, and it's been in the sunlight. So let me give you some little rules of nitroglycerin that will help you. It should burn under the tongue. When the patient places it under the tongue, it should burn. And when I say burn, it's not like their mouth's on fire from a chili pepper, but it should tingle, it should burn. It's reacting. It should give them a slight headache pretty rapidly. They'll get this flush headache that comes over them, and then it'll pass. It doesn't last too long. And it should relieve the chest pain. It should lower their blood pressure. So if you took their blood pressure right before you gave it and then right after you gave it, it should drop it. I like to have my chest pain patients sitting down or at least lying down or at least sitting down before I give them the nitroglycerin. I'm not going to give one to somebody standing up because their pressure could fall and they could fall over and hit their head. And if they were already taking Plavix, now I've got a head trauma on top of a cardiac event. And which one gets treated first, and that becomes a problem for the hospital. So have your patient sitting or lying down, ready to lay down once you give that nitroglycerin. If it doesn't burn, doesn't change blood pressure, doesn't give them a headache, you might start questioning whether it was any good or not. Now, as a paramedic, I should have fresh nitroglycerin in my drug kit. As an EMT, you do not. EMT, you have to just go get theirs and help them with it, okay? Right patient, right time, right date, right all that. Even though all those conditions are met, once again, it may not work, may not be effective. So where would I get new nitro? If the patient's wasn't any good and that doesn't seem to be working, where would I get good nitro? ALS. And if I've got a heart attack victim, I probably want ALS anyway. But I will not delay treatment or transport to wait on them. Okay? They have to be able to control that airway. So if they're unconscious or something, nope, don't do it. They could aspirate it or suck this thing down their lungs. And it's a little bitty tablet. I mean, it's smaller than a Tic Tac. If you cut a Tic Tac in half, you'd still be bigger than a nitroglycerin tablet. Now, some patients, because it's easier, have nitro spray instead of a tablet. I like the tablet better. I really do. I like the tablet better. The spray, Sometimes it gets on the side of the mouth. Sometimes it gets in my eye, like at 3 o'clock in the morning. I have sprayed it in my eye one time, and that'll be the last time you do it. From then on out, you will always check which way it's pointed, and it will cause your eye to vasodilate. It'll be red for a long time. Plus, when I give a tablet, I can see it. With the spray, you're like, well, is that a half a spray? Or I always wasted one. One deal is I make sure it's pointing in the right direction. Number two, I make sure that I'm going to get a full spray the next time. So the patients may have a spray of nitro. Regardless if it's a spray or a tablet, the dose is the same. Somebody might ask you about this one day. 0.4 milligrams is how much nitroglycerin is in one tablet or one spray. 0.4 milligrams. Because it's metric, we can change that to micrograms, and you'll actually hear nitroglycerin spoken of in micrograms all the way into the healthcare system. But it's the same number, 400 micrograms. So what's the dose of nitro? 0.4 milligrams or 400 micrograms. Just for your relevance, that's a big dose. That is a big one-time dose, isn't it? We have a name, Jordan, for big one-time doses. We call those a bolus. If I give a big, relatively speaking, one-time dose, it is a bolus. If the nurses in the ER start a nitroglycerin drip, in other words, they put an IV in the arm, there's nitro in a bottle, and it drips into their arm over an extended period of time, that's called an infusion. Infusion. That's the difference between a bolus and an infusion. To put it in college student terms, a bolus is a shot. An infusion, I'm going to sip on it here all afternoon. Keep a nice therapeutic level going. Maybe that helps. Large one-time dose, bolus. So when I give nitroglycerin to my patients as the EMT, I'm giving them a bolus. And what's the dose? 0.4 milligrams or 400 micrograms. I'm telling you, that's a relatively large dose. If I give it through the IV, it may start at 5 micrograms a minute. It's significantly different, isn't it? So there's the spray. If you pick this up, you'll think, well, you said no plastic. That is a plastic sheath around a glass bottle. So you may think it's in plastic, but it's not. There's an actual glass bottle inside that plastic. Make sure it is pointed away from your eye. I'm stressing that, okay? You'll do it once because it stings and burns and dilates. Your eyes get red and it waters for 20, 30 minutes. This is the tablet. And it actually says right there, 0.4 milligrams. And if your eyes are really good, you can see this 1-150th thing. In parentheses, 0.4 milligrams is 1/150th of a grain. Now, us old timers, we used to measure some medications in grains. Aspirin, penicillin, nitroglycerin. Some things were measured in grains. And yes, that was actually compared to a grain of wheat back in really, really old times. How much does something weigh? It weighs about as much as a grain of wheat. That was the standard. It's kind of like, how long is a foot? Well, which king is in power? Because ever how long his foot is the unit of measure. We got smarter. We invented the metric system. We standardized some things. So now we don't have to measure in grains anymore. But you may see, and obviously you'll see it on the bottle, so I just want you to know what that means, okay? So 1/150th of a grain is the same as 400 micrograms. You get to paramedic school, we'll tell you how to convert between the two, but it's beyond the scope right now. Relieves angina pain, and we'll know in the next couple of days what angina pain is, but basically it just means chest pain. Angina means pain. Angina pectoris, where are your pecs? In your chest. So angina pectoris technically means chest pain. And this should relieve it. What if the nitro's good? What if it burned? What if it lowered the blood pressure? What if it gave the patient a headache, but the chest pain persisted? Is it a problem with the nitro?
No.
It's probably a problem with the heart. It means we're not warning you anymore with pain. Now we actually have the full-blown heart attack. So a patient whose pain does not relieve with nitro just escalates up the severity factor if the nitro was proven to be good. Like, that should work, and it's not working. You're probably having the big one. You're probably having the big one. And every time I say that, I think of the sitcom Sanford and Son, where he grabs his chest like, I'll be there with you, looking up at his wife in heaven. These events are often called widow makers. So more about that in a couple of days to come. It relaxes veins. This is a smooth muscle relaxant, is how this works. The purpose is to take that coronary artery that's pinched down or in a spasm and open it up to allow more blood to go through. But it does that all over the body. So that's why the blood pressure plummets, because we lose the tone of the vasculature. Now the other side of this equation is this is kind of short acting. It doesn't stay around for long. That's why when you go to the hospital, they'll give it to you in a continuous infusion. It doesn't stay around real long. It's not stable, is it? So it's not going to, the effects won't last forever. It's kind of short acting. And so we can repeat this nitro, can't we? Up to 3 times. Most of the rules say up to 3 times, as long as the blood pressure is good. Now let me settle some controversy. You may see a blood pressure of 90 as the cutoff. You may see a blood pressure as 100 as a cutoff. I believe your textbook calls it 100, if I'm not mistaken. I'm not worried about the numbers too much. I just want to know, I want you to know that I could give it and the blood pressure could fall drastically quickly, especially if they're taking ED med concurrently. So if they're on Viagra or Cialis or Levitra or something. Nitrates for chest pain. If you see the ED commercials, it says, caution, be sure you consult your doctor if you take nitrates for chest pain, because they compound each other and the blood pressure can get super dangerously low. So hope he's not lying to me when he gets his nitroglycerin. Most doctors will not prescribe both, but your cardiac doctor may not know about your online doctor. So it gets kind of confusing. There it is. Should not be used with ED meds and may cause a mild headache. So we've already talked about that. It's going to do all that. There's nothing there I didn't say. 1 spray is 1 tablet. Wear gloves? Yeah, sure. Let me tell you something. You're not going to pick up a disease from someone's mouth through your fingers. Now, if you're kissing them, that may be different. I'm going to wear gloves anyway, but we haven't really spent a lot of time with PPE yet. Let me just warn you that people will put on gloves and they think they're protected from diseases, and they are not. That glove really doesn't do much. Yeah, it keeps wet stuff away from me. I don't want to grab a sheet soaked in urine to move a patient, but I'm not going to catch a disease from that if I was to. As long as your skin is intact, meaning that it's not chafed open cut sores, hangnails, stuff like that, you're not going to pick anything up. The glove sure doesn't protect you from sharps, like needles or broken glass or gravel on the highway. I'll tell you the story because I want you to be aware of the shortcomings of things like gloves. I had a paramedic partner, and he and I picked up a trauma patient from the highway, the gravel highway, edge of the highway, gravel, picked him up with a backboard, and we get to the hospital and my partner's glove was torn and his skin was torn because the gravel tore the glove, right? Then we find out before we leave the ER that the patient was HIV positive. He lost his cool. As he freaked. He freaked. He was young like me, had new babies at home like me. This could be life ending, if not life changing at the least. So he went for testing every 3 months, every 6 months, once a year, every 5 years, and he's still in a test deal, all because of that one exposure. That was an exposure, but the glove didn't protect him, did it? He should have had leather gloves on top of those gloves to help in the environment which he was in. Gloves don't keep things out of your eyes, out of your mouth, out of your nose. Doesn't keep it off your arms. And yeah, you might wear the big old AI gloves up to your shoulder. You need to relax, but you also at the same time don't need to walk into a place and think you're invincible because you got gloves on. But there are other EMT schools, and you can help me here, Billy, who teach BSI Scene Safe. And if you look at a skill sheet, if you don't say BSI Scene Safe, you fail the skill no matter how well you've done it because you didn't address BSI Scene Safe. I call all that bogus anyway. I don't stress about that. You know why I don't stress about it? I got a better rule. I think it's better. There is no safe scene, and there's no BSI that's going to 100% protect you. Good enough? Good enough? Even the disease people, like the Centers for Disease Control, they don't mandate that you wear gloves to give an injection. What? But every one of you will be popping gloves on before you walk out of the ambulance. And then you'll go into the house and you'll do all this stuff, and then you'll come back to the ambulance and touch everything in it. Maybe even the steering wheel. You might even see people drive with the gloves, and that was just, I was like, oh my God, would you pull the gloves off? Because all that nasty that you just got off of Johnny is now on the steering wheel. Change glove between patients. I'm going to work on Riley and she's bloody, and I come over here and work on Chas and she's bloody. You've got a disease. Now she's got the disease. You with me on this? Change gloves. Change gloves. The number one disease transmission precaution, ding ding, washing your hands. Soap and water. There are test questions about that. It's not gloves. It's not hand sanitizer in the hallway, which is one of the worst things that can ever be used. If you want to ask me why, I'll certainly tell you why. But you go out and hit that hand sanitizer, every time you see one of them, you're hurting your immune system. You're destroying the good bacteria on your skin. What survives that hand sanitizer, which it doesn't kill everything, what survives gets stronger. It's kind of like taking a daily dose of antibiotics. If you're worried about your hands, instead of that hand sanitizer, you should go to the bathroom and use soap and water, which will lift and flush it off your hands, okay? No surgeons going into surgery just using hand sanitizer. Where do you see them at? They're in the sink with their elbows down, and they walk out like this, and somebody helps them put gloves on. So everything's dripping off their elbows. Those are terrible. Now, how many people will fight me on that? A bunch. I'm going against the system, am I not? Especially during COVID. There were people stealing those on this campus because they were freaking out over COVID. It's called soap, people. Do not bathe in antibacterial soap. You can use antibacterial soap on your hands if you want to, but do not bathe your body unless you want you a nice case of athlete's foot. You disrupt the normal flora of your body. The flora meaning the bacteria microbiome on your skin. That is a protective microbiome. That's how germs get on your skin, and the good bacteria will kill them. They're part of you. They're part of your existence, both internally and externally. Don't destroy it with the overuse of antimicrobial products. Boy, it's a catchy thing though, isn't it? I gotta sanitize the room. Little Johnny, my 2-year-old's gonna come in here. Have you ever seen those memes in the bathroom where they have that towel that just rolls back on a roller and everybody uses the same towel? We made it. We made it. Careful with that stuff. It's a false sense of security, and you can end up with diseases because of that. And if you don't believe me, ask me what C. diff is someday. And you'll see C. diff when you get in the ambulance. C. diff is that overused. Maybe not externally as much as internally. That's not something you want. The cure for it is a fecal transplant from a good donor. Somebody goes and poops in a bucket, a bag, and you take that bag to the doctor and they will blend it up and put it in a tube back down in your intestines to get you over C. diff. It's so bad, we have a hard time finding healthy stool donors. That's how many people don't have healthy poop, that the bacteria are so out of balance in their poop. Okay? I didn't mean to go off on a tangent about personal protective equipment, but you've got to use common sense when it comes to that stuff. We do give injections, and our IM medication is what at the EMT level? What drug do we use to give? Epi. And if your local protocol allows it, it's that drawing up a 0.3 epi from a container, but the national curriculum looks at the EpiPen. So if I go up, little Johnny's got an allergic reaction to a bee or some peanuts or something, and the nurse says, he's got an EpiPen, I'll get it from my office. You can administer or help administer the EpiPen. At the EMT, at the paramedic level, I can make that decision to go get epinephrine and draw it up myself and give it to you without the prescription of an EpiPen. State of Texas is a little funny on that. Don't quote me on this. There was a representative, state senator or something, who had a child or a family member die of anaphylaxis. And then when he found out that it was illegal for an EMT to give epinephrine, unless it was in the form of an EpiPen, they tried to change the state rule. And don't quote me on this, but I think they did change the state rule. It's a delegated practice state anyway, so the physician can give you that ability if that medical director wants to. Okay? So that's why we had you draw up the 0.3 of epi the other day. So you do need to know the doses of epinephrine. It is 0.3 milligrams for an adult. It's half dose for a child. Cut off on a child, I don't know. When does a child not be a child anymore? I'm still my mother's child. When does a child not become a child anymore? I've seen some big old 7-year-olds that probably need 0.3. And in paramedic, we give it off of a weight based anyway. And then I've seen some really small 7-year-olds who probably could get the 0.5. According to HA and others, signs of puberty. But I don't need to worry about this at the EMT level, because who's making that decision for me? Well, the physician who prescribed it to the child. EpiPens are expensive. So your 0.15 EpiPen may be several years old, and the kid really has shot up in the last couple of years and probably needs a 0.3 now. But mom and dad said, that thing was $700 and we're not about to waste it. They are very expensive. It's not the drug that's expensive, it's the delivery device, the spring-loaded needle, that's the expense. And it doesn't cost 10 cents to make that. But the pharmaceutical companies have you because who's not going to buy it if it saves little Johnny's life? You're not going to walk away and go, I ain't paying that. Now, you could go down to Tractor Supply and get all the materials you needed for about 12 bucks to make about 100 EpiPens. If that doesn't piss you off about the state of the world today, then I don't know what it's going to take to make you angry about that. Knowledge is power, guys. Knowledge is power. The more life-saving a drug, the more it will cost. And I'm not a socialist per se, but I think everybody ought to have the ability to get a hold of that without fear. We give it IM because we don't have to find a vein. Plus, we don't want epinephrine in the vein for this event. We want it to be a little slower to be absorbed. There is a hot needle. When I say a hot needle, that means a needle that's contaminated. So it needs to be disposed of and be protected from subsequent sticking. It should retract itself back into the EpiPen once it's administered, but if it does not, then you could get stuck with the needle yourself, and there's nothing that will freak you out more than a cross-contamination needle stick. So when I use the word hot needle, it just means it's live, it's contaminated. If I'm starting an IV, I've got a hot needle, and I'll actually say that around people because, you know, we're in a cramped environment, back in the ambulance, maybe even going down the road, bumping around, I've got a hot needle. It goes in a sharps container. I never hand that needle to someone else. If I can't reach the sharps container, I have been known to just to drop it on the floor and say, needles on the floor, and then somebody will pick it up. That's not recommended practice, but I'm certainly not going to hand it to you. If I can't get it to the sharps container, I will drop it. You can pick it up safely if you can. If you cannot, nobody wants to go clean an ambulance and find that needle on the floor. You just don't want to do that. And they can hide in the strangest of places. I grew up in an environment back in the late 80s, early 90s when a paramedic would start an IV and have the hot needle. He or she would just stick it in the seat cushion to get it later. May not even been a sharps container in the ambulance. Crazy, huh? Crazy. I rode on an ambulance where a box of gloves would last about 6 months. We just wore them when we thought we needed them, not every time we got in it. So that was odd. The HIV thing got really going well. Really started seeing a lot of cases of it in the 80s and 90s, late 80s, early 90s. And you also started seeing an increase in latex allergies because everybody's wearing latex gloves and wearing latex condoms. And so now we're at a point that we have latex-free medical clinics and latex-free ambulances. Latex comes from a tree, a rubber tree, and it's got a protein in it. So we become sensitive to that protein. So now you see it. Now latex I prefer a latex glove over a natural glove. It's got a more natural feel to it and stuff. So some things have changed. Be careful with that needle. Patients know they're going to get a shot, and how many kids like a shot? I haven't found one yet. Hey, you're an EMT. You kind of mess around with the doctors, don't you? Am I going to get a shot? That's the first thing a pediatric's going to ask you when you show up on an ambulance. Am I going to get a shot? Do you lie to them? Never lie to them. Never lie to them. If you lie to them and get caught in the lie, you've lost them. You'll never get anything else done with them. We don't need to lie to anybody. So it is a fight or flight drug. It's a sympatho. Do you remember back? Wrote it over there on that board. M-I-M-E-T-I-C. What?
Sympathomimetic.
Very good, Chas. Sympathomimetic. It mimics the sympathetic nervous system. So it creates a fight or flight response. So I'm going to ask some questions and I want true or false as an answer, okay? Epinephrine is an alpha-1 stimulant.
True.
It is true. Epinephrine is a beta-1 stimulant.
True.
Epinephrine is a beta-2 blocker. False. It's a beta-2 stimulant as well. The indication for using an EpiPen in anaphylaxis is beta-1, beta-2, alpha-1? True. True. We want to shrink the periphery. In other words, we want to take the vessels out in the arms and legs and tighten them up. We want to make our heartbeat stronger. We want our bronchial tree to open up. That's the beta-2. Because when someone's allergic to peanuts or shellfish or whatever set them off, they vasodilate, their heart gets weak, and their bronchial tree constricts. So they can't breathe and they have no blood pressure. They have cardiovascular collapse. Epinephrine reverses that. Okay, it's fast on, fast off. Gus, what do I mean by a drug that's fast on, fast off?
It works fast, but then it also doesn't last long.
Okay, the half-life is about 3 minutes. That would be a long half-life here. It works within seconds and is gone just about as quick. Therefore, some patients will have 2 EpiPens with them. Some will have 2. Now, it's not $700 anymore. Now it's $1,400. So the odds of them having 2 may be just a little less than them having 1. But even if you give them the second dose, is it fast on, fast off? It's not fixing the root of the problem. Epi does not fix the root of the problem. Epi just gets them out of the immediate life danger, and we need other drugs to do the problem fixing. Specifically Benadryl. Now the EMT does not have the Benadryl, nor does the patient necessarily. Who does? Paramedic. So if I'm using an EpiPen on a patient, is it an absolute that I've got a paramedic en route? If possible, yes. If not, am I transporting? Yes. Because it's not going to fix it because Gus said it was fast on, fast off. It's not fixing the allergy piece. And the allergy piece is helped to be reversed by the Benadryl. And Benadryl is not the end of the line either. We can use steroids to reduce that as well, some corticosteroids. So paramedics can bring all that, or I can get them to the hospital where that can continue. But if you're using EpiPen, it is a mandatory transport, okay? Or at least a mandatory ALS intercept. And I'll meet the ALS on the highway. I mean, I'm going to start moving because Gus says it's a fast on, fast off. And it may just come right back, okay? If it does come back and you're under the protocol that allows you to draw it up out of the vial and give it, get on the phone with Med Control. They may ask you to repeat the dose or something. Cool? Chess, did you cheat? You promise? Okay. Yeah, it's right there on the board. Sympathomimetic. Please understand that the patients will start getting jittery and anxious because you just kind of ramped them up. Do expect the heart rate to go up. Do expect the blood pressure to go up. And in this cases, I want that. I want the heart rate up and I want the blood pressure up. Anybody in here have an EpiPen? You do? For... You have one? Yeah. Oh, I thought you had your hand up like you had one. I'm like, he's not going to tell me. He's just putting his head on down.
I've had one before.
For what?
Allergies.
To what?
Peanuts.
You still allergic to peanuts?
Yeah, maybe.
You haven't tried it out?
I've ate some before and just nothing happened. When I was younger.
All the more reason not to eat peanuts. Peanuts do have a compound in them that your body doesn't like. But boy, we raise kids on peanut butter, don't we? I'm not going off on that, I promise. Naloxone. Naloxone. A competitive opioid antagonist. It's a competitive opioid antagonist. We spent quite a bit of time with this the other day. This drug goes in and knocks the opioid drug out of the receptor site and blocks it. So it's a competitive receptor binder. It gets in the way. It does not remove the opioid from the bloodstream. Therefore, depending on the drug and how much they have on board, this may need to be repeated. I talked to you about the dangers of this drug, as it could start seizures. It could have withdrawal symptoms and make the patients very agitated and angry. They could vomit because it disrupts their brain so much that it can make them nauseated and vomit. I hope with all that you see that this is not relatively safe. It's not just safe like the media would have you believe it. And I think I just said all that in those four bullet points there. Consider your safety. There is nothing more agitating than having your high ruined. Except dying. But it's a peaceful death. You've shut the brain down so much it really doesn't have any issues. What was that magical word we used when we said we give just enough of something to get the desired result, but not a full-blown amount? Titrate. Yes, titrate. At the EMT level, you do not have that ability. If you are a high school teacher and you give naloxone or Narcan to a student that you suspect has that overdose and you stick it up their nose and it reverses it, great, awesome, you saved a life. But if you're an EMT and you go to the back alley homeless camp where needles are all over the ground and it's obviously people are abusing opioids and drugs back here, and I was to give that full tilt amount without titration, I could have the severe withdrawal effects, correct? But what else do you have that the high school teacher didn't have at your disposal to help save this life? More specific, the ability to breathe for them. If a patient's not breathing, can you breathe for them? I hope so. That's why you're here. I hope so. So, what's probably the best alternative to Narcan for the EMT with a suspected drug overdose?
From a druggie?
Breathing support.
Yeah.
Breathe for them. Breathe for them. Because your Narcan may be this big mega dose and that's not cool. There's been some controversy in the hospital setting versus EMT setting or paramedic setting. I had a student a couple of years ago talking about they saw Narcan being administered in the ER when they were doing their clinical rotations like you're going to do, in November or so. So they were in there watching an overdose, and the nurse said, "This is the drug that you slam and run." And when the student told me that, I was like, yeah, ha, 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 that's funny. And they're like, what are you laughing about? I said, well, you don't slam it. You titrate it. If you do slam it, I can understand why you run. Because it says consider your safety. Come to find out, the nurse was serious. The concept of titration had not been taught to that individual. Yet, what was that individual saying to fellow students or other students? Wrong information? So if that student hadn't brought it to my attention, and that student never had the ability as an EMT or paramedic to give Narcan, how would they give it? Slam it and get out the back doors, right? You can have the ambulance to yourself. Fight yourself in there for a while, because I'm not fighting with you. We titrate it, guys. We titrate it. The teacher doesn't have that ability. The police officer doesn't have that ability. But they also don't have the ability to use a back valve mask to breathe for the patient. Okay? As a paramedic, I prefer my patients to be in that state. They don't talk back. I get consent. They're easy to manage as long as I can do that. Is that if I can keep their oxygenation up, vital signs are supported, isn't it better I do that than run the risk of aspiration, seizures I can't stop, plus my own personal safety? All right. What you know, what you think you know. The media would have you believe there's all there is to know about Narcan. So that's the MAD device. You saw one the other day. Either technique is appropriate. It's just dispersing that. Oh, hit the wrong thing. It's just dispersing that across the mucous membranes, and it's readily absorbed there. Sugar cannot be. Okay, so sometimes I think people see this and people wake up and say, he must have gave him sugar up his nose. No, he gave him Narcan. Intranasal. I have never given that drug intranasal. Never. I didn't even know it existed back in the day. It was always IV. Always give it IV. But in doing so, I could do what with it? Titrate it. Okay, oxygen, we won't spend a lot of time about this. We all know what it is. MDIs and nebulizers, you guys put your hands on this so we can get through that pretty easy. You're turning it to a mist and a spray. The nickname for this one is the peace pipe. That's a 15 by 22 adapter right there, so I can also put this on the bottom of a non-rebreather mask. I can pull the mask off and stick this on the bottom of it. Now I have a mask. A lot of my COPD patients were so tired anyway that they even had trouble holding the peace pipe up to their mouth. And I wasn't going to hold it for them, so I'd put them on a mask and be done with it, okay? This was my least favorite way of doing it. I always found it just lying in their lap because they would drop it. They're that weak. So you can convert that to a mask. This meter dose inhaler, this is prescribed to them. You have to shake it because that's a powder and it settles to the bottom. So you shake it, you put it to the mouthpiece. This is just a device that's added to it, so it's better directed into the mouth. I don't see that to be necessary a lot of times. Maybe with kids it would be. You shake it, you have them exhale completely, and then when they inhale, that's when you give them the hit of it. And then you ask them to hold it there so it gets down and gets absorbed into the target organs. No problems there, right? The prescription will tell you how often you can repeat it. If you can repeat it, these are also known as rescue inhalers. And I'm here to rescue you. Where is your inhaler? You should not see one of these at the paramedic level. We'll take the same drug and put it in this. When I first started as a paramedic, that's how we would give it. And our patients got real smart. They knew if they had an asthma attack or a breathing problem that I would come out and I would give them a dose of that, and I'd have to give it to them because it's been used, and I'm not going to use it on somebody else. Well, there are like 150 doses in that thing at $100 a pop back then, and we were leaving it. It was costing the service money every time we'd get a COPD call. We started noticing a trend. People picked up on this. I know how you can get you an inhaler. Call 911, they'll leave it with you. We're going to do a societal experiment in this class, I don't know, whenever I feel like the need to do it. And it is, could you survive in poverty? And I do that because of the people you go out and encounter. And it's a really fun exercise to talk about in class. But that's one of the ways you can survive in poverty. How do you get your medications? These are the same people that know which churches on which days give a meal, and that's how they meal plan for their family sometimes. They know where the best garage sales are. They know how to get someone out of jail. They know how to generate $150 cash immediately. We'll do that one of these days. So there's the old peace pipe method. In a closed ambulance, you can't help but get a little bit of that yourself. So keep that in consideration. If you ever feel a little jittery or a little wired up after you gave someone a breathing treatment, it's because you took a sympathomimetic yourself. Probably not as concentrated as they did, but if I'm down here listening to her lung sounds, I promise you I'm getting some of that. Once I give them medication, what do I have to do immediately afterwards? Reassess. Not only for the desired actions, but for adverse reactions. If I have a medication error, what do I do? If I make a medication error, what do I do? Call for help. Let med control know. Admit it. Admit it. Don't try to cover it up. I heard something the other day that I really didn't like the way it sounded. I don't think there was any malintent. And I would tell the guy to his face I didn't like the way it sounded, because I know the guy and I know there's no malintent. Some drugs we have in our ambulances, we have the counter drug or the antidote drug, if you will, for it. Let me be clear. We do not carry Narcan because we carry morphine. If I give a patient morphine and they already have morphine on board and I didn't know it, yes, then I may be able to use Narcan. But I really don't chase med errors with other meds. I don't. You may let a physician do so. Unless it's a toxicology issue and I didn't create the med error. But rarely, what's the best way to avoid this? Don't make the med error. Every time I give you this statistic, I don't think it's true. I have a hard time believing it myself. And I said to you, I think one time, that over 3,000 patients a month die due to med errors. Every time I say that, I think I'm quoting it wrong. I read a more recent statistic over the weekend. 383 people a day. $383 people a day die of med error. Whew. Admit it. I wonder how many die that it didn't get admitted to. Admit it. Own up to it. Take safeguards to protect it. And it's even worse in our business because do we have a controlled environment? Do we have, is it still called a Pyxis, Jordan? Mm-hmm. Can you tell the class what a Pyxis is in the hospital?
Pretty much like a big old refrigerator full of meds.
It's a vending machine for medications.
Yeah.
And you go up there, you put in your credentials so you can at least talk to the machine, and then you put in what you want out of the machine, and then it'll kick open a drawer that has nothing but that medicine in it. Now, a nurse lost her license, and I think she got, don't quote me on this, I didn't follow the story after this. She just went and she didn't know how to spell the drug, so she started typing the drug. This is the danger of autocorrect and autofill and autocheck and autospell and all those automatic things, those artificial intelligent things. She started typing in the first couple of letters of the drug because she didn't know how to spell it. Well, it went ahead and populated it, and she went, sure. And I'm making this part up just for explanations. If she typed in Sudafed, she got out succinylcholine. One is a decongestant, one is a paralytic. I do know she got a paralytic out of the Pyxis and administered it. And the guy went paralyzed and died because he stopped breathing. Pyxis is there for safety, and it probably prevents a lot of med errors, but even the technology itself can create an issue. How do you prevent things from happening? It's called the 5 E's of injury prevention. You're probably going to find this in an assignment somewhere. The 5 E's of injury prevention. 5 E's of injury prevention. And I won't go through the whole list right now, but one of them is engineering. We have seat belts in our cars that are engineered to prevent injury. The other one is enforcement. We have police officers driving around making sure you're wearing that seat belt because we don't want you to get injured. Another one is environment. Well, back in the 90s, and some of you may have seen these cars, we wanted you to wear your seat belt so much that when you got in it, it would automatically put on the shoulder harness. It would come up down the door jamb. You're buckled in, right? No, you had to put the pelvic or the lap belt on. Well, people wouldn't do that because they thought, what? Well, I'm already buckled in. I don't have to do that. And so now when we were having crashes, people were getting decapitated because they were slipping out, but the only thing catching them was the shoulder belt because they didn't wear the lap belt. Engineering went wrong. The Pyxis is an example. Oh, it's great. It will spell the words for you. Yeah, I think that's it. Make sense? And I don't know about you. I don't know how much you read online stuff, but the lack of proofreading is scary, especially by journalists. Like, what are you saying? Here's one that I will call the news station to report. No one is care flighted. You with me? Care flighted is not a verb. You could be flown to a hospital. You could have been airlifted to a hospital. You could have went to the hospital by air ambulance. But no one is care flighted. And I see that in media all the time. Hey, if Nosy Becky next door says you were care flighted, well, it's Nosy Becky. But a journalist on the news should not say care flighted. I wrote to KXI one time and they said they'd take care of that, and it was for a while, and then I saw it again the other day. Care flighted. I give up. I give up. It's not a verb. There is a company called Care Flight, and they must have an outstanding reputation because their proper noun has been changed to a verb. You never hear them say they were eagle-meted. How would you like to be on Eagle Med and fly someone and the news says they were care flighted? Notify med control when you messed up. Be honest. Go to your supervisor and say, I messed up. How can I help you help the rest of us prevent this med error again? And he says, well, what caused the med error? And you say, every time you order that drug, it's in a new container. Last week it was a red container. Today it's a pink container because it's a different manufacturer. Do you know that there was a fire department down in Dallas called Dallas Fire and Rescue that were hiring so many people who couldn't read that they taught them how to give drugs by the color of the boxes. Give one red box, then one blue box. 5 minutes later, give a purple box. the literacy level of the people they were hiring could not make out lidocaine, epinephrine, sodium bicarb. The whole paramedic class was taught by colors. Now, if I get a new manufacturer, or I happen to be colorblind, it would result in med errors. And that's just a very common thing that happens. All right, let's have a review. Luke, we'll start with you. We'll just kind of work around. Pharmacology is defined as?
Study of drugs and medication.
You sure? Like you're 100% sure?
Yep.
No doubt in your mind. Luke. Come on, man.
What was it, Delta? D?
Never doubt yourself if you're sure, if I just happen to be standing over you trying to change your mind. He was right the first time. Why did you change your mind?
Playing psyops with me.
Why did you change your mind? This person of authority who's standing up ridiculed you in front of others, or started ridicule, just giving you doubt, and you changed your mind. What should he have done?
Stuck with it.
And not just stuck with it, defended it. When I said, "Are you sure?" he should have said, "Brandon, pharmacy relates to drugs. Ology is the study of." Oh, okay. Did I do that on purpose?
Yes.
So in paramedic class, you got to make 100 on your drug test or you don't get out, right? You can't use a calculator. You get 3 attempts. I had a student in the back of the class back there where I could be sitting. And I'm sitting up here, they're taking their drug, and you can hear sweat hitting the floor, right? Everybody is on edge that day. And this guy back here in the back, I knew he'd finished first. He was bright, and he brought me his paper, and he handed it to me. And it's, several sheets of handwritten, and I'm thumbing through it, and I'm going, "You sure about that before you turn it in? You want to look at that before you turn it in?" What's he do? I haven't graded it, but I've kind of graded it. All right, I'm like, "You sure you want to turn that in?" So he goes to the back of the room and he reworks every problem. He gets the same answer he got the first time. He reworks them again. And he comes up here and he says, "Take it. If I miss something, I'm out of this." And I said, "I hope you didn't change anything because you made 100 the first time." He said, "I didn't change a thing." But he sure was mad at me. He sure was mad at me. Why did I make him do that?
Because you'll experience it in the field.
You're going to hit the wall of doubt, and you got to get through it. Sometimes when you're taking a test, and I haven't done it yet, and I don't know if I will because of the way we're testing, probably at the end I'll look over and go, or sometimes I'll just stand behind you while you take your test. I'm not asking if you're cheating.
No, you're just mean.
What am I doing to you? What'd Luke call it? Psyops or something? Well, I'm a lot nicer than the screaming mother. I'm a lot less intimidating than a dead 2-year-old with dad going, "I got to get to him." All right. Good job, Luke. Stare it. Looking for the false statement. Which of the following statements regarding medications is false?
C.
C. Are you sure?
Yes,
Why?
because that's correct.
Just because you said so, right? Why is
To
that?
the next page and we'll find out.
Why is that? Why? Give me rationale.
What?
You have to justify your decision.
So,
So why did you pick C?
because they don't all have to be prescribed by a physician,
All what?
over-the-counter drugs.
I don't think any of them have to be prescribed by. You can just go in there and buy them, right? Okay. All right. I'll agree with that. Which of the following routes of med administration has the fastest effect? Not affect. Affect is how you act. Effect is how it works. So guess.
B.
B?
Yes.
What is B?
In the vein.
Okay.
Intravenous. Or intravenous.
Intravenous. So why is that correct?
Because it goes directly to the bloodstream instead of having to go into the muscle and then into the bloodstream or through the membrane into the...
Does this all make sense to you now? Okay. Trying to think of your name. I'm wanting to say your nickname and I can't. What is it? What's your actual name? Clayton? Layton. Layton. When administered to a patient, a meter dose inhaler will? This is a tough question. Why A?
Their answers seem right.
Oh, a little process of elimination thing, right? Are they plausible? You'll hate the National Register because you'll walk out and go, there were 4 answers and 3 of them I knew could be right. Might have been trying to look at the 4th one. They're all plausible, aren't they? They're not made up. This is just delivered via radiation or, some goofy thing. They're all plausible. But you picked A because you said the others are no good. Do better than that. Do better than that.
What's the only one that seems justifiable? I mean, if you break the other ones down, then there's still...
Okay, that's a test-taking technique, but in the real world, I don't have, I may not give you the, I may say in the real world all that apply. Why is A the best answer?
Because it's true.
Why is it true?
It does deliver the same dosage.
That's the whole word metered, isn't it? That's the whole idea behind the word metered. Okay. Metered means measured. Chas, let's move to you. Managing a 60-year-old woman who complains of crushing chest pain. Her blood pressure is 84/64 with a heart rate of 110. Med Control says assist her in taking her prescribed nitro. After receiving this order, you should. I interrupted a pattern there, didn't I? Christian's like, thanks. Appreciate that. Why did I interrupt the pattern?
Find someone that's not good.
No, I'm not that mean. Why did I interrupt the pattern? Because patterns will lead you down complacency. So I have to correct the complacency.
I'm gonna go with B because the blood pressure is already low. So it
You don't like the blood pressure and you want to make sure the doc hears the blood pressure.
correctly.
And what else? Every one of these distractors has the word and in it. That's the echo effect, right? Did you hear me? And did I hear you if you heard me?
Can you repeat back to me what I
You
said?
didn't say, hey, doc, you dummy. We can't give him nitro if the pressure is that low. He's probably going to reply back, then why'd you even ask? Okay, good. Good. Amber, who needs this? Who needs this question? Let's do it. Activated charcoal is indicated for patients who have ingested certain drugs and toxins because it pretty tough question if you don't know it. It's hard to rule things out with the process of elimination, isn't it? 10 seconds. Your patient's dying. Come on, dude. 5, 4, 3, 2.
C.
You're guessing now. So pressure of time went against you and you made a decision. If that had been an action to the patient, because it's not C, you see what happens there? So I like to use tests this way. It's a judgment, it's a mind game, it's what you call it?
Psyops.
Psyops. Because this is how med errors happen. If I'd have stayed down the line, you would have become complacent. If you don't know why you're doing it, then you don't know why you're doing it, which is just terrible. You're allowing someone to change your mind that was already committed. I put you against the clock and everybody's screaming, do something. You're even screaming to yourself, I need to be doing something. I'd rather you go take a blood pressure than give the wrong medicine. Above all, do no harm. That's the big rule in this business. Above all, do no harm. So I'm showing you how your brain will mess you up in a high stakes, high risk environment. Activated charcoal is a adsorbent, not an absorbent. The difference between the B and the D. So activated charcoal is just typically charcoal that has been ground up or activated to be a fine powder. It's carbon, and that's a 5-sided molecule, and we can make carbon fiber out of it. We can make life out of it. It is a miraculous. We make diamonds out of it. By the way, if you ever store your diamonds in your jewelry closet thing, if your home, your drawer or something, and the house burns, so will the diamond. You'll just find the gold band without the diamond in it because it'll burn like charcoal. That'd be an expensive fire, wouldn't it? I cook my burgers over diamonds. It's a very neat molecule. It's called organic chemistry. Grind it up. 1 teaspoon has the surface area of an acre, 1 acre of land. And so when it gets a hold of these chemicals that are foreign to our body, it will grab it. And they found traces of this in mummified prehistoric people. And they figured that people knew if they could eat charcoal from the campfire following a food poisoning or some type of poisoning, that would help. I guess if they found it in a mummified man, they're getting a little bit too late or something, I don't know. It's a suspension, so it will settle out. It's often mixed with sorbitol. It doesn't have to be, but often it's mixed with sorbitol to make it easier to drink. It's a sweetener. Plus, it's also an osmotic diuretic. It pulls fluid into the GI tract. So when you go to flushing it out, it works better. We usually don't give it anymore. We don't give it much anymore because is this a high aspiration risk? So activated charcoal in the lungs is not a good thing. A quick little story, and we'll take our break. Picked up a lady who had tried to overdose on some tablets. They took her to the ER. They gave her what? PO, activated charcoal. They made her drink a lot of charcoal. This was attempted suicide while at work, and she was in business dress. She was actually in a dress, in hose, very put together, professional dress, and I guess she tried to do this at work. My job was to move her from the ER once she was cleared medically to behavioral health to get treatment for the mental health side of this, the suicide attempt. And she could walk, she was ambulatory, and I went in there and said, Mrs. Whoever, come with me, we're going to get in the ambulance. So her and I crawled up in the back of the ambulance, and I opened the door and I let her crawl up in there, step up in there, not crawl, but you know what I mean. Now her face was blacked out with the charcoal. It had charcoal running down her neck and stuff, and this stuff is very nasty. And she was a beautiful woman, like I said, well put together. Don't know what's living upstairs, but it obviously was bad. But the osmotic diuretic effect of the GI tract had started. And so when she stepped up in the ambulance, charcoal stained stool started running down the back of her leg. And I felt so embarrassed for her. I felt so embarrassed for her because she couldn't control it. And that's how much water gets pulled into the gut. And that's coming from the interstitial space, by the way. So if you wonder where that fluid came from, it came from the interstitial fluid that's surrounding all the cells and pulled it into this. And so she actually had to set on additional sheets in the ambulance while we went over there because this was dripping out. I did the best I could to be tactful with it because she was certainly embarrassed about it. Not only embarrassed because of what she had done, but now she's got this going on and her teeth are blacked out from the charcoal. So it is a very nasty procedure. And they could also vomit. But it's very, very effective at adsorbing the poison because it has such a high surface area. If you ever get a deep freezer or refrigerator that the power gets disconnected to it and the food rots inside it, and you think, who unplugged that? Or why'd the power go off? Clean it out and throw a bag of charcoal in there opened up and it'll absorb all the odors. So it's very, very powerful. That's why you have charcoal water filters, charcoal in your fish tank, charcoal in your breathing mask if you're around a hazardous environment. Very effective. Lighter fluid. Yeah, petroleum based. I'm not being a smart ass Billy, but yeah, if someone's ingested a petroleum base, they don't get this. You know how they make charcoal? Huh?
From burnt stuff.
From burnt stuff? Kind of.
Wood,
Wood? Yeah, you can get it from wood.
actual charcoal.
Now the charcoal you cook with is not 100% charcoal. It actually has coal in it, so it'll burn longer. Now, unless you're buying 100% lump charcoal, that's wood that's burnt without the presence of oxygen. So you can make your own charcoal at home. You just take a barrel, put a bunch of wood in it, get it going, and then keep it hot, but don't let much air get to it at all. So it's wood burnt without the presence of oxygen. Gus, let me tell you, we're on break. Let me tell you how you can get you a beer at a bar.
Sure.
Try to challenge someone of where